Welcome to the lecture on functional testing for return to play decision making. I am Major Arun, and in this session we will focus on how to guide return to sport, not simply when. Return to play is one of the most critical and complex steps after ACL reconstruction, where clinical judgment, objective testing, and patient psychology converge into single path where treating clinician can take whether an athlete ready for return to play. Traditionally, many decisions have been based only on elapsed time, such as 9 months after surgery. But this approach ignores individual recovery, variations, and risk factors. Today, we will explore how structured functional testing combined with clinical and psychological readiness provides a safe and evidence-based framework for clearance whether an athlete is ready for return to play. By the end of this lecture, the one should be able to know these objectives. Firstly, the objective is to understand the role of functional testing within criteria-based return to play framework, where time is combined with objective benchmarks. Secondly, we will identify validated and feasible tests, including their cutoff scores and practical alternatives for clinics without advanced equipment. We will learn to apply objective return to play criteria holistically, including psychological readiness alongside with the physical testing. Finally, we will examine decision aids and strategies to reduce bias so our return to sports judgments are consistent, reproducible, and athlete centered. And by the end of this lecture, you should be able to design and apply a robust functional testing battery for safe return to sports decision in case of athletes of various sports. Actually, why this functional test matters to us. Evidence says time alone is insufficient. Two athletes may both be 9 months post-operative time, yet one may be functionally ready and the other still at higher risk for re-injury if we send both early return to play. Functional testing combines strength, balance, agility, and hop performance, basically the explosive power. And psychology is not the least to assess how an athlete returning, not just when. This integration allows us to detect deficits that are invincible in simple clinical examination but critical under sports demands. A structured and repeated testing creates checkpoints for safe progression and allowing us to adjust training loads and timelines while minimizing re-injury risk. Ultimately, functional testing ensures we base clearance decisions on capacity and control, not just dates on the calendar. Before moving into functional testing, several clinical prerequisites must be satisfied in each and every athlete. The athlete should be pain-free during testing with full active range of motion and no reactive effusion after advanced loading. Complications such as arthrofibrosis or persistent anterior knee pain must be excluded since they invalidate test results. Knee stability should be acceptable, confirmed both clinically and, when indicated, radiologically for laxity. Finally, the surgeon's clearance based on intraoperative findings and graft healing protocol is mandatory. Functional testing never replaces surgical considerations, it complicates them. Let us look at the overview of functional criteria. Functional clearance depends on meeting a combination of strength, agility, and hop and psychological benchmarks. Isokinetic strength symmetry should be above 90% of limb symmetric index with hamstring to quadriceps ratio between 0.6 to 1.0 for knee stability in athletic population. In case of elite level sports where pivoting and cutting activity is very much required in the sport, the ratio should be maintained is 0.9 to 1.0. Balance and agility are measured with tests like Y-balance test and T-test, where cutoffs include an anterior reach difference less than 4 cm on dynamic balance in Y-balance test and agility performance at least 90% of baseline when we compare baseline value. Hop testing across multiple planes is single, triple, crossover, and 6-meter hop should achieve at least 90% of limb symmetry index with good landing mechanics. There should be no compensation during these testing methods. Finally, psychological readiness is quantified using ACL return to sports index, where score above 60 to 65 indicate adequate confidence and low fear of re-injuries. Let us examine these criteria in more detail. Isokinetic quadriceps testing, the symmetry should be more than 90% is considered the gold standard. Lower symmetry means the knee cannot safely tolerate various sports loads. The hamstring to quadriceps ratio below 0.6 signals inadequate hamstring contribution and increased risk of re-injury. Hop test should consistently exceed more than 90% of limb symmetric index, but both distance and movement quality must be evaluated. For the Y-balance test, the anterior difference greater than 4 cm between sides correlates with higher injury risk. T-test agility should reach 90% of baseline, or athlete should be able to complete this T-test protocol within 11 seconds of time. And the ACLR return to sports index scale, the psychological readiness measure should exceed more than 60 to 65 before the clearance. This slide highlights The practical tools most widely used. The T test for agility, the Y balance test for dynamic stability, and various hop tests as I mentioned: single hop, triple hop, crossed hop, or 6-meter timed hop. These battery for functional power and endurance. Each test challenges a different system: agility, look after, deceleration, and cutting mechanics. Y balance evaluates proprioceptive control under dynamic range. The hop test assesses multiplanar power and landing control. Using them together provides a comprehensive profile of the athlete's functional readiness. Remember that quality of execution matters as much as quantitative scores. Faulty mechanics, despite symmetry, are red flags. Single hop test. This is the single hop test. The athlete performs a maximal forward hop on one leg, landing with stability and control. The key is to maintain knee alignment, avoiding valgus collapse and excessive trunk sway. This test evaluates unilateral power and limb symmetry, critical for return to play after ACL reconstruction. Always compare the operated leg to the non-injured side and ensure safe landing mechanics to reduce re-injury risk. The triple hop test involves three consecutive forward hops on the same leg. Emphasis is on distance covered with controlled landings. Proper hip, knee, ankle alignment and soft landing through the quadriceps are essential. It assesses strength endurance and neuromuscular control under repeated load, reflecting sports like demands. Watch for fatigue induced valgus or poor balance during this sequence. In the crossover hop test, the athlete hops forward on one leg while crossing over a center line. Each hop challenges multiplanar stability and proprioceptive control. This test highlights the ability of the reconstructed knee to tolerate rotational and lateral stresses. Clinically, asymmetry or loss of alignment indicates deficits in dynamic control that must be corrected before progression. The 6-meter timed hop requires the athlete to cover 6 meters on one leg as quickly as possible. Focus is on speed with controlled rhythmic hops. This test assesses both power and reactive stability under time pressure. Compare side to side differences carefully, as even small deficits may indicate incomplete rehabilitation. The T test is standardized agility drill involving forward sprint, lateral shuffles, and backpedaling in a T-shaped pattern. Correct posture includes low athletic stance, quick directional changes, and proper foot placement. It evaluates multidirectional agility, acceleration, and deceleration. These are all key components of sports readiness. Ensure the athlete maintains trunk control and avoids knee valgus during lateral movements. The Y balance test is performed in a single leg stance, reaching in three directions, that is, anterior, posterolateral, and posteromedial. Correct execution requires maintaining balance, hip stability, and knee alignment. This test quantifies dynamic balance, proprioception, and limb symmetry. Deficits greater than 4 centimeters compared to contralateral side may indicate elevated re-injury risk. Few controversies between baseline versus contralateral comparisons. A key issue is whether to compare the result with baseline pre-injury levels or with the contralateral limb. Baseline comparison detect residual deficits more accurately because the contralateral limb may also be deconditioned after surgery. For Hop test, contralateral comparisons are often practical, but baseline data remain more sensitive. For balance and agility tasks, baseline data are particularly useful as small deficits can be overlooked when only comparing limbs. The practical recommendations: use baseline data whenever available and contralateral comparison when baseline data are missing, but interpret results with caution. Let's talk about some valid and feasible alternative testing criteria. Gold standard measures exist but are not always available in all institutions with all clinicians. Isokinetic dynamometry is the gold standard for testing. We all know it's not very common with all institutions or with physical therapists. But handheld dynamometer or 8 repetition maximum knee extension can be used as alternatives. For movement quality, 3D motion capture during drop jumps is ideal, but 2D video analysis is feasible in most of the times. Field-based hop and agility batteries are valid for clinics without lab equipment and allow repeated and low costing. The principle is to choose validated tools appropriate to your setting. A test is only useful if it can be applied consistently and repeated over time. Let us see most oftenly commented topic, the 9-month rule. The so-called 9-month rule has often been used as a fixed cutoff for return to play criteria in athletes. Recent research shows that simply waiting 9 months does not reduce ACL re-injury risk if criteria are unmet. Athletes who meet discharge criteria can safely return at variable times, while those who do not remain at risk even beyond 9 months. Younger athletes, in particular, have higher rates of second injury regardless of timeline. Therefore, the emphasis should shift away from arbitrary time points to completion of rehabilitation milestones and functional testing criteria. The quality matters. It is very important in each and every aspects of rehabilitation, duration, and procedures. Beyond numbers, execution quality is critical. Single leg counter movement jumps and drop jump reactive strength index provide insight into neuromuscular control. Observation of knee valgus movements during landings helps detect risky movement patterns that raw distance won't reveal. Combining vertical and horizontal tasks ensures comprehensive assessment of both linear and multiplanar function. Finally, avoid making clearance decision based on a single test. A robust battery combining strength, hop, balance, agility, and psychological measure is essential. To conclude, safe return to sport is a multidimensional, criteria based process, not a single test or a date on the calendar. We must include not only functional testing criteria, but also psychological readiness, rehabilitation adherence, and clinical stability. Validated test batteries with strict cutoffs provide objective guidance, but they must be interpreted in context and repeated across the rehab timeline. Decision making should be bias aware, patient centered, and aligned with athletes' sports demands. Regularly updating protocols with new evidence and outcomes data ensures the best possible balance between performance and safety. These principles are supported by ASPETA clinical practice guidelines and recent systematic reviews and few multi-center studies on functional testing. Key papers include Kotsifakis ASPETA guidelines, studies on the 9-month rule, and recent reviews of validity and feasibility in clinical testing. Together, they confirm that structured functional testing is central to safe return to sports clearance. For optimal recovery, it is essential to follow the rehabilitation exercises in the demonstrated sequence, beginning each session with a structured warm up and concluding with an appropriate cool down. This systematic approach ensures that each step builds on the previous phase, promoting safe, effective, and progressive rehabilitation. Patient videos and images shown in this presentation are used with prior informed consent. Jai Hind.